complication was recovered from the patient. In 70 days after left hemicolectomy, the patient was operated. Transversostoma was extraperitoneally closed. On the first postoperative day, general conditions in the patient remained satisfactory, but scanty fecal discharge was received of the drain form, liquidation transversus place. The patient was diagnosed with the partial failure of colonic anastomosis with forming incomplete tuberal colonic fistula. The edge of the skin would were shared of the phlegmona anterior subabdominal wall lesions were found. Peritoneal lesions were negative, considering the delaminations and adequate domination of the colonic anastomosis. Failure area was decided to use a vacuum system. The wound was backfilled by straight form rubber obturator imposed by Shell's film Eoban. The negative pressure was during by connecting the active vacuum aspiration device and the wound. During 3 days after the start of vacuum aspiration, decisions were changed daily, including satination of the wound with an antiseptic solution, actinisept, and landmark necrotomy. For 3 days with the active vacuum aspiration, it was obtained up to 3 milliliter of wound exudate with and abdominal of face. After 3 days external the wound, we cleanse it of necrotusions, reduce in size, active granulation aberrate. In 5 days of contusion, active aspiration ligation was performed. After removing film from noteworthy measures of foam rubber spawned overlay with no cessation of pure inflammation.
Excuse me very much. You have to conclude because your time is up, okay?
Yeah, time is up, and unfortunately, I can't read.
Do you want to add any conclusion, maybe, to sum up?
No.
Okay.
Don't run away. No, you're. That's a very good method. We know that vacuum therapy or sponge surgery, how we call it sometimes, is excellent. It's not answer to all surgical problems, but certainly it's a very good solution to many complications. We're very impressed by the device that you used here. What is exactly that? Is it constructed by yourself? Is it company made?
It's made by Hyako. Maybe you know.
Yeah. So this is a pharmaceutical company that actually manufactures this kind of devices. Little one?
These devices.
Yeah.
Yes, the devices is we must be
Prepared by yourself.
Yeah, prepared by yourself.
This is what we thought. We are impressed by your invention here, really.
Because our comment was related to the fact that we are too experimenting with various homemade approaches to this kind of therapy, because normal this commercial type sets are very, very priced, and we are looking for different solutions. And just one general comment: you spend about 80% of your time talking about the past history that was not much relevant for this case. So for your future presentations, just try to emphasize the on your study and on your ideas. Thank you.
Thank you.
Okay, and the next participant, please.
Good morning, Honorable Committee, dear fellow students. My name is Lucina Hachatrian, and I would like to present the study performed by Student Scientific Group at the Second Department of Surgery, Jagiellonian University Medical College, entitled Short-Term Results of Laparoscopic Transperitoneal Adrenalectomy for Incidentaloma. Adrenal incidentalomas are tumors of the adrenal gland discovered during imaging tests performed for other reasons than primary adrenal disease. Their prevalence is reported to be as high as 4% of the CT scans in the general population. And when a tumor meets indications for a resection, laparoscopic adrenalectomy is the main approach. The aim of our retrospective study was to assess the early outcomes of laparoscopic adrenalectomy for incidentaloma. We included 261 patients admitted for adrenalectomy to the Second Department of Surgery, Jagiellonian University Medical College, and between 2003 and 2015. 70% of patients were males, aged 56, with mean BMI 28. And they had 126 had a tumor on the right side, and the rest 135 on the left. We assessed the effect of factors like age, BMI, ASA grade, history of abdominal operations, size and site of adrenal gland, and the result of histopathological examination on the short-term results, which were the operative time, intraoperative blood loss, intra and post-operative complications, and length of stay at the hospital. So now let's take a look at our results. As we can see, the operative time was around hour and a half, and it was higher in patients with higher ASA grade. Also, it was associated with the occurrence of complications. We also found correlations between the operative time and the size of the adrenal gland, the BMI, blood loss, and length of stay. The blood loss was around 60 milliliters, and it correlated with age and BMI. We also found correlation between the size of the adrenal gland and age of the patient. And this pie chart shows the result of the histopathological examination. As we can see, 4% were adrenocortical carcinomas, almost 40% were benign adenomas, 16% were pheochromocytomas, and the rest were other tumors. So to sum up, we can say that from this study that simple parameters such as age, BMI, or ASA grade may be helpful to predict the short-term results for laparoscopic transperitoneal adrenalectomy for incidentaloma. Also, it was a surprise that there was such a high number of pheochromocytomas, which generally present with a host of symptoms and various clinical manifestations. So this discovery may lead to an assumption that a great deal of pheochromocytomas are asymptomatic and may be undiagnosed before the surgery. Thank you for your attention.
Thank you very much. Well, again, it's difficult to comment the material from my own department, but here in your presentation, you missed several points. One that should be found here is why those patients were operated. So what was the indication? So was it the size of the tumor, primary discovery, about 4 centimeters? Was it a tumor that was growing during the observation period, follow-up period? Or was it the tumor that was not fulfilling the criteria of benign tumor on CT? And that's the information that is missing on this poster. And there are 2 more missing informations that that you promised to give. You, in the left lower corner, you said that there will be some short-term results: operative time, intraoperative blood loss, and complications and length of stay. And those 2 are not addressed in the results section, while you addressed a very important subject, but you did not say about it in methodology, which is histology. So this is just for preparing your presentation in the future. That's a very nice material, nicely presented. But whenever you promise to give us something, you should give it. Okay, so that's my remark for your future presentation. Nevertheless, good conclusions and very good presentation.
Thank you.
Congratulations. And just a simple question, did you find any factor that is more or less able to be modified pre-operatively on the safety of the procedures? Because we don't have no actually great impact on BMI or length of operation or other factors, because they are more or less related to the surgery itself. But pre-operative modifications in any factor, could they lead to more safe surgery?
Actually, for example, it may be the good preparation of the patient to the surgery, good hydration, and also when we can before predict that there may be some complications may occur. So maybe then the surgeon will be better prepared if something happens.
Okay, thank you.
We invite the next participant.
Dear committee, dear students, I would like to present you a comparison of urological knowledge amongst medical students of all years at the Jagiellonian University in Krakow. So prostate cancer is the second most common cancer in men, which accounts for 13% of cases, and the number of patients suffering from this disease increased about 5 times in the last few decades, and the urinary bladder cancer accounts for 7% in men and 2% in women. So due to this fact, in this research, students' theoretical knowledge and practical skills, which help to diagnose and treat mentioned conditions, were tested. So the urological knowledge was scored by the questionnaire. Questions were divided into 3 categories. The first one was general urological disease, the second one was case studies, and the third one was ability to perform fundamental urological procedures. The aim was to compare the urological knowledge among all of the students of the medical of all years of medical studies, and to check how the knowledge is changing among the students. So analyzing answers and questions, we divided data into 6 groups of the most common urological diseases. So I will tell you about a few of them. The first one is hematuria, and this is, as we know, the most common symptom of the urinary bladder cancer, and only 7% of the respondents would give the patient a referral to oncologist. What is interesting, that in case a patient was female, only students of the 3rd year would give a referral to the urologist more often than to oncologist and gynecologist. The other students would refer such patient to likewise often to urologists and to gynecologists. But in case the patient was male, all of the students would send him directly to the urologist. The second was a testicle tumor, and here students answer better for the theoretical questions than to questions about practical skills, as we can see on the graph too. And a kidney tumor. What about kidney tumor? Here students from 1st to 5th year of study would refer this patient to the oncologist rather than to urologist, and students answer similar in case the patient was female and male. What about prostate problem? Here we have a big difference between students from the clinical and preclinical studies. The older one marked that the only level of PSA is not sufficient when we're talking about diagnosing problems of the prostate, but it is not so clear for younger students. Here, we also have a correlation between years of study and correct answer. However, all respondents claim that detecting a tumor in a prostate is an indication to direct such a patient to the urologist, but faster than direction when direct patient when we detect a hardness and immovable prostate. So the conclusions that we did is that urological knowledge of all students is insufficient, and there is a correlation between correct answers and years of the study when we are talking about questions about urological knowledge, but the correlation does not work when we are talking about questions about practical skills. Yes, and as we can see that the urology is not popular specialization among students because only about 5% in a group of 343 respondents would choose the urology. Thank you for your attention.
That's a very important study, I must say, and those are very good results, very interesting results. And it's very important for all the people that are dealing with students' education. Probably we should do similar studies in all other disciplines of medicine, not only surgery or surgical subspecialties. So it's a very good study, very well presented by you. Unfortunately, we cannot read much from this. So mostly what we benefited is from what you said and from what we can see. Perhaps for future presentations, you should include less of the results, less words, and perhaps just select most important things so that it's more clear. But nevertheless, the study itself, it's excellent, and the mode of presentation failed a little bit.
Thank you.
Mm-hmm.
Could you tell us some details about how did you perform this questionnaire? I mean, you gathered all the students at the same time, or
no.
those questionnaires?
I did this research with my colleagues, Karolina Kaink and Lukasz Radziszewski. So we just, I took second-year students and fifth-year students, and my friend Lukasz, he took first year and third year, and Karolina took fourth year and sixth year. So we just divided our questionnaires between us. So yeah, and we gave it to the students when they had time. So that's
because the conclusion is not very optimistic in some areas. That I was asking this question because the actual knowledge could even be worse than you just showed us. Because if you distribute those questionnaires, it's quite obvious to me, as some other people's, that they may use some additional sources of knowledge filling this kind of questionnaire. So because so the general message would be the knowledge would probably be even worse if some students would be deprived from some additional sources of knowledge.
Yes, but very often
it's more pessimistic. That I assume that this is much more pessimistic that you show us.
Yes.
That's a very important study.
Okay. Thank you very much.
Excellent. Congratulations.
And the next presenter, please.
Good morning, everyone. What do you think? Should medical students gain the theoretical knowledge as well as practical skills during medical studies in the urogenital examination? Yes, I think they should. But what's the truth? Do they gain or not? No. Okay. Our aim was to analyze the experience of Polish medical students in the examination of the urogenital area. We used a self-prepared online questionnaire which was filled by 1,073 students. It's a lot, I think, yeah? Yeah. And they are from 12 Polish medical universities from all of the years. And 28 questions concerned, for example, data about affiliation to the SSG and the number of performed examination and the students' approach to the to this procedure, to the examination of urogenital area. What about and statistical analysis? For the statistical analysis, we used Statistica. What about our results? Over a half of the students have never performed a urogenital examination, while 45% have never been demonstrated this procedure. And almost 10% of the students have had the opportunity to take the examination, both males and females, as often as the practice only on phantoms. And number of the students who had never performed the examination had significantly decreased after completion of the gynecology or urology courses. For example, for gynecology, from 51% to almost 3% for gynecology, and from 50 to almost 4% for urology. And a quarter of the students avoid the urogenital examination, while 35 volunteer. What about our conclusion? There are a significant group of the students who had never performed the examination. In this group are the students from the last, 6th year of the study. And also, it's a significant group of the students who avoid the examination. Thank you.
Thank you. That's an excellent study, very similar actually to the previous one, but results are more clearly presented, so congratulations. And
but there was the newer version, but yeah. No way it's the oldest one.
Yeah, but the point is, you said that those were students from different years, from different universities. Did you do any comparison between those who already had urology course and those who did not, the gynecology, or those who did not?
Yes.
How many of them had a chance to do this examination, if not on hands-on training on patients, if on simulators or phantoms or anything like that?
Unfortunately, course gynecology or urology not help to yes, because before it's for example, for 5th year students, it's 3% of students who have never performed, and after something similar.
Something similar.
Yeah.
How do you think what could improve this situation?
I think we have to increase the number of the clinical exercises in case not only on phantoms but on patients.
Mm-hmm. Yeah, it's very difficult practically because of many social obstructions here. I know how we teach our students to do digital rectal examination. We take the opportunity of colonoscopy done under general anesthesia, so then they can practice, then they can exercise on real patients. The problem is not only how those studies are how the teaching is done, but how the patients respond to that, and that's a big problem. So probably phantoms should be a general solution for all those problems, but the issue is very well addressed, and that's a very good study. Plus, more than 1,000 students. Congratulations.
And I think a decreased number of students in a clinical group, because
Yeah.
6 is a...
Yeah, if you try to imagine yourself as the patient and let your prostate be palpated by the group of 10 students. Yeah, I know what you mean.
I want to congratulate you for your, I would say, very good behavior towards the audience when you present your data, because you try to involve us in this case, and this is well, worth of mentioning, definitely. But the conclusion is rather sad for us as a teachers. So, well, some kind of knowledge you may gain by yourself, but with physical examinations, you should need some guidance, and the majority of the students do not have such a guidance, and it's a real pity for us as teachers, not you as students.
Thank you.
So we would like to invite the next participant.
Hello, ladies and gentlemen. My name is Jakub Frączek. I'm a fifth-year medical student from Jagiellonian University Medical College. Today, I would like to share with you the results of our study concerning the issue of preoperative risk stratification in patients undergoing vascular surgeries. Let me begin with a brief introduction. Vascular procedures are associated with a high risk of complications. Cardiac complications, such as myocardial infarction, are frequent and constitute more than 30% of all adverse perioperative events. That is why accurate risk prediction tools are valuable both for the clinician and the patient in the decision-making process. Revised Cardiac Risk Index is a commonly used scoring system which estimates the risk of cardiac complications after a surgery. Excuse me. However, it has been proved that RCRI, Revised Cardiac Risk Index, has several limitations and thus significantly worse when applied to vascular surgeries. Therefore, we have tried to assess the predictive performance of a serological biomarker, high-sensitivity troponin T. We hypothesized that an elevated baseline troponin level may be associated with the preceding damage to the myocardium and increased risk of unfavorable outcomes. So let me explain what is Revised Cardiac Risk Index. It is a 6-point scale calculated by granting 1 point for each clinical characteristic listed in the table. High-risk surgeries are those above inguinal ligament, intrathoracic, and intraperitoneal procedures. Patients also receive 1 point for history of heart failure, ischemic heart disease, prior TIA or stroke, elevated serum creatinine, and diabetes mellitus requiring insulin treatment. As we can see on the graph, the majority of our population had an RCRI score of 1, which equals to an about 1% risk of complications. A large group of patients scored 2 points, which is associated with an over 6% risk of complications. A minority of them scored 3 or more points, putting them at an 11% risk of adverse cardiac events. In this study, we examined 895 patients aged 45 or older undergoing abdominal aortic aneurysm, peripheral vascular, and carotid artery surgeries. Every patient was clinically assessed to establish their RCRI score and had high-sensitivity troponin T measured before the surgery. Afterwards, a cautious perioperative monitoring and 30-day observation was conducted with a phone follow-up made by researchers. So let's proceed to the results section. Here we have receiver operating characteristic curves, representing the ability of troponins and RCRI to distinguish between patients who suffered from complications and those who remained event-free. The first graph shows ROC curve for the occurrence of myocardial infarction or cardiac arrest. The second one concerns death in 30-day period. Let's look at the comparison of area under curve values shown on these bar graphs. Troponins have an AUC of 0.73, which means that 73% of the times patients with an adverse event had higher troponin levels than those who remained event-free. As we can see, for both outcomes of interest, the AUC value of troponins is significantly higher than that of RCRI, with p-values of less than 0.001 and less than 0.05. And that leads us to a conclusion that high-sensitivity troponin T measured before the surgery is more accurate than the routinely used revised cardiac risk index in prediction of unfavorable outcomes after major vascular surgeries. Troponins may be considered as a very useful part of the perioperative period, particularly in this field of surgery. Thank you for your attention.
Congratulations. It's difficult for me to discuss the problem of troponin. I'm a general surgeon, so we know very little about it. But it's a nice study, although I do not fully agree with the title and the rest of the study. With any biochemical measurement, it's very difficult to stratify a patient. If you want to stratify a patient, you need to set cutoff values. So if troponin is within this value, then we have a risk of that. Within this value, it's a risk of that, etc. So what you have actually proven, you've proven a correlation between cardiac index, cardiac risk index, and troponin, and it was very well proven. You have proven that the risks related to myocardial infarction and death could be predicted by the troponin levels. However, it did not help you to stratify the patients. So that's just one remark. Nevertheless, that's a very good study.
Thank you very much. And yes, I completely agree that risk stratification is putting patients in relevant risk categories. So I think we should try to use
maybe
troponins.
You should try to do ROC analysis.
Yes, that's an ROC. It's not a correlation. It's exactly
that's ROC.
ROC.
Okay, I did not see it. Okay,
so
sorry.
The closer the curve is to the x-axis and here to 1,
okay,
the better the test.
Yeah. Okay. Sorry. Yeah, I did not look at it. So my mistake. Okay.
Thank you.
More questions.
Two questions. Congratulations for you for huge, enormously large number of patients. Nearly 900 of patients is very big population. Could you explain us what was your role in this kind of paper?
Yes, the students' contribution to this study was, I think it was a great effort of students because they took part in every stage of the study, from recruiting the patient to gathering clinical data, filling contact report forms, to putting them in the database, making phone follow-ups, and the statistical analysis itself.
Great effort. But you showed us that the area under the curve was about 0.73. It corresponds to about sensitivity and specificity of about less than 80%. So from clinical point of view, I don't know if it's high enough to be implemented in clinics. And second, all of your observations are made post hoc. I mean, do you have any prospective data with categorizing patients according to your results, or do you just do it all by post hoc analysis?
I completely agree that study which is prospective has much more value than retrospective one. However, this should give us some idea of the trend and for the future design of prospective studies, which we are planning. And the AUC value is moderate. It's not high enough for clinical use. However, let's look at the common used revised cardiac risk index. It's even lower.
Yeah, don't take it as a criticism. We are impressed by the quality of study, and this is why it started our discussion, because there is something to be discussed. So that's our remark. Congratulations.
Thank you.
And we invite the next person.
Their scientific committee. My name is Marta Taurit and I'm from University of Latvia, Faculty of Medicine. And I would like to introduce you with our experimental work, investigations about the influence of frequency and the electrode material in radiosurgery. I would like to mention also that we were working in collaboration with Leibniz Institute in Dummersdorf in Germany, because it wouldn't be possible to do in vivo experiments without them. As you know, radiofrequency is widely used method in different fields of medicine. And it was introduced as a method in electrosurgery with a minor lateral damage. So for further refinement, it is necessary to define the influence of different factors in radiofrequency surgery. In our research, we investigated different parameters. We used two different frequencies generators. One is 400 kilohertz and one is 4 megahertz. And also we used different types of electrode material, which was tungsten, steel, and nitinol. And also different speeds, 1 centimeter per second and 0.5 centimeter per second. In our experiment, we included 12 young male pigs, and we did 7 cuts on each side on neck region. And each cut was done by these frequencies, different cutting speed, and different electrode material. And to provide standardized cuts, my professor, he constructed a new device, cutting simulator, which provides these standardized cuts that they are like in constant speed. So after surgical procedure, we obtained specimens preserved in formal where material was stained with hematoxylin and eosin sliced, and slices were made. So what kind of results we gained from these specimens? The lateral damage by radiofrequency incisions has the following characteristics: a small called this lateral damage zone, and we measured it in micrometers. And the lateral reaction was slightly different between different electrode materials, and the best results were done by nitinol electrode, which was introduced by my professor, who is scientific. And the cutting speed in a range we use in our experiment, 0.5 and 1 centimeter per second, actually didn't show any significant difference in this changing. And so we came, and also these frequencies actually didn't show changes in lateral damage zone. So we came to conclusions that newly developed cutting simulator is able to provide comparable results for further evaluation of electrosurgical techniques. The cutting speed in a range we used in experiment has no significant influence on lateral reaction changes. However, the duration of the energy has an essential meaning. Tungsten, steel, and nitinol, which we use in our experiment, have slightly results and frequencies as well a little bit. And in the future examinations, we will do, like we are doing, that is the second part of our work, that we are doing healing process evaluation. And it is the best done by animal experiments, where the best comparability in skin is given by specimens on pig skin due to the similarity of human skin. Thank you for your attention.
That was an interesting study. I don't think I understood everything that you did, but generally what you were doing, you were comparing the skin incision done with electrosurgical unit, yes?
Yes.
Comparing the amount of necrosis, the sideburns, and damage of tissue, yes?
Yes.
Okay.
That is one part. The second part is the healing process that we are comparing on 6-day and 12-day.
So the aim of your study was to find out the most optimal condition under which there is an effective cut with good hemostasis, yes, with minimal tissue damage. That was the point.
That's true.
Yes?
That is the point in radiofrequency, and why this method is coming in the future, really used. And actually there is one standardized formula, lateral heat formula, which includes these parameters. There is output energy, electrode size, but we choose material because there was that came from my professor, the scientist, that he's using radiofrequency for the beginning. It started. He's a otolaryngologist, and that works well, but there is no histologically in evidence-based studies. So we did it, and I'm really happy that I was included in such a big.
Yeah. So practically the study was done in Germany, yes? You went to Germany, and that's an excellent study. There are not so many experimental studies in medicine trying to answer very basic questions and trying to optimize it. So yeah, congratulations.
And it's more in microsurgery and plastic reconstructive surgery.
Exactly.
So maybe it's not like in in this session. So
the primary aim of your future device, let's say, would be to construct a cutting device for general surgeons, or just a device that will destroy the tissue, for example, like radiofrequency devices to ablate tumors?
You know, I listened before about this colorectal operation, where the man said about that there is this flat polyps, and physically it's not possible to remove them, but with radiofrequency, if you do endoscopically the procedure and the electrode is radiofrequency, it produces the heat. So it is possible, because there is some kind of like electrodes with a loop, and you can just
scratch. But so you aim at inventing a device that would help you to precisely dissect something.
Yes, and especially in the dangerous zones, whereas
do you have any data about the damage created by the current standards of cutting devices and your approach? Because
you mean in my experiment, or in
your experiment, or in the general area you are involved with?
Lateral damage
because
area.
There are some effective devices to cut quite precisely, and you are working on another one. Yes. So, do you have any comparisons between the current standards and your invention?
Right now, I'm just comparing like lower frequency surgery device with a higher, so I don't have
so
results.
You don't know yet if it's as effective as the current state of art, or it's more effective. You don't know it yet.
Not yet, because it's still in the study process, so it will be done.
Thank you very much. Very good discussion.
And next presenter.
Ladies and gentlemen, bariatric surgery remains the most successful method of treatment of morbid obesity and control of its associated diseases such as hypertension or diabetes mellitus type 2. Among the most common procedures are sleeve gastrectomy and gastric bypass. There have been observed some changes in taste preferences after bariatric surgeries, but still little data is available. Therefore, if such changes were true, this would increase the effect of weight loss and therefore increase the efficiency of bariatric surgery. Therefore, the aim of our study was to investigate the changes in taste preferences and appetite in patients undergoing bariatric surgery. Our control group consisted of patients with a section of colorectal cancer. All patients were submitted to laparoscopic surgery at a single institute and were guided according to the ERAS protocol. We excluded those taking medicines of a known influence on taste perception, smoking cigarettes, and also patients who, due to post-operative complications, were disabled from early oral nutrition. In order to reach our aim, we created 2 separate protocols within the range of 6 core flavors, which are sweet, umami, sour, spicy, bitter, and salty. The tests were taken on the pre-operative day and on the first post-operative day. And the tests were rated using numerical rating scale, where 1 stated for untasty or unappetizing, and 10 stated for very tasty or very appetizing. Firstly, to investigate taste preference changes, every day we prepared 6 solutions based on oral nutritional supplement of a neutral taste, and we added different substances giving different flavors. The patients picked them randomly and assessed them, and in the appetite test, the participants were asked to rate their general appetite, and also they were presented with pictures of food items corresponding to different core flavors. For example, we showed them a cake which corresponded to sweet flavor, and we asked them to rate their. Overall, we investigated 72 patients whom we divided into 3 groups depending on the surgery type they underwent. In the bariatric groups, there was a higher percentage of women, and also the average age was lower there. In the result test, there was a significant change only in the bariatric groups. Those operated by sleeve gastrectomy has shown a decrease in all 6 tastes, in all 6 flavors, and those operated by gastric bypass has shown a decrease of appetite only in sweet and spicy flavors. And there were no changes in the control group. On the other hand, there were different tests. To sum up, our study has shown that although the bariatric surgery does not influence taste preference, it quickly decreases appetite and the theoretical desire to eat, which may increase the effect of weight loss and therefore increase the efficiency of bariatric surgery. Our study was financed with student grants competition of 2015, organized by Student Scientific Society of Jagiellonian University. Thank you for your attention.
Congratulations. You addressed a very difficult subject, which is extremely difficult to measure, and that's a very useful attempt. We know from discussion of our patients that they are changing the way of eating the tastes. The people who did not like sweets half year after bariatric surgery eat sweets, or they did not like meat even though they were meat eaters before. So it's a very difficult thing to measure, and that's a very nice effort. what you probably you should continue the study for long-term results, not just after surgery. And just after surgery, that's like a storm of many hormones and other substances that may change everything. While the patient gets adopted to the new situation in their life, they will change a lot. I know that there is a parallel study done on dietary habits of those patients before and after, but you should include the patients when they get some stabilization with the way how they deal with food and eating. One remark similar to one of the previous, too much texts and not very good to read. Okay.
I would like to ask another participant, and it will be the last one before the break. So be patient.
Ladies and gentlemen, my name is Jonas Dragon, and I represent student science of the second Department of General Surgery, Jagiellonian University Medical College in Krakow. I would like to present a thesis entitled, "Does sarcopenia influence short-term outcomes in patients undergoing laparoscopic colorectal surgery with enhanced recovery after surgery protocol?" To begin with, I need to explain what actually sarcopenia and myostatosis are. Sarcopenia can be defined as progressive and generalized loss of skeletal muscle mass and strength, whereas the second one, myostatosis, is described as fat infiltration in skeletal muscle. Although sarcopenia was widely reported in many scientific theses and articles, there was one aspect of it lacking. So far, sarcopenia has been analyzed only in patients undergoing traditional surgical procedures or with metastatic spread. The lacking aspect is the influence of sarcopenia on patients undergoing laparoscopic colorectal surgery for cancer combined with ERAS protocol. To check this influence, we performed a study containing 124 patients to find out whether they suffer from either myostatosis or sarcopenia. We had to outline manually contours of L3 skeletal muscle appearing on preoperative CT scan, and then by using we chose proper density values in order to check area of muscle. Then the result divided by square of height, and we got SMI, which stands for skeletal muscle index. The outcome measures were complications rate, length of hospital stay, as well as functional recovery parameters. When we come to the results, we need to mention that ASA score, as well as severity of neoplasm, similar regarding all the patients. Myostatotic and non-myostatotic or sarcopenic and non-sarcopenic groups were compared. When we take a closer look to length of hospital stay rate measured in Clavin-Dindo classification, we also cannot notice any significant statistical difference. Also, functional recovery meters revealed no significant dissimilarities. Tolerance of an oral diet on the first post-operative day, mobilization of the patient of as well as time to first flatus remained the same regardless of the presence of muscle depletion. To sum up, the impact of sarcopenia and myostatosis. Thank you for your attention.
Congratulations. The same remark. The presentation will benefit if you will include less text. The same text. It's an important study, and you presented it very well. That sarcopenia generally is bad concerning the outcome of surgical patients. It can contribute to very untoward effect, while it could be overcome if you operate the patient laparoscopically and the ERAS protocol sufficiently. So it's a nice study.
Could you tell us who did the measurements? Because measuring muscle areas in nearly 200 of patients is quite laborious. I know it from my experience. So were the students?
Actually, it were the students themselves who first had to call all the patients to get CT scans on the CD, then outlining, as I said before, but outlining manually contours of the muscle on these CT scans to calculate SMI value.
So congratulations for you for a very, very hard job. There are many papers that emphasize that actually sarcopenia is not for those who look for predictors of post-operative complications, because there are a variety of different factors of them. But I don't believe that this is the only one. Do you have any correlation between sarcopenia and other markers of malnutrition, laboratory or muscle strength or whatever? Do you have any such correlation?
Actually, as this study is post hoc, so it is a retrospective study, we were not able to measure muscle strength and laboratory results, because this study is retrospective. We should create some new prospective study in order to check these values. So have any.
And a final comment about your conclusion that you said that this modern post-operative care may decrease the unfavorable effects of sarcopenia, but you don't have any data to support this idea. So it's just a simple speculation. You didn't show us that sarcopenia had any negative effect on patient recovery. There are some reports in the literature that it might have such effect, and there are others that say there's no way that sarcopenia could affect post-operative complications. So you should be a little bit more conscious kind of statements.
Thank you very much.
So now we would like to invite all of 10 minutes long break.
To była właśnie sytuacja poster 2. Te maile po prostu w zupełnie innych miejscach, więc ciężko, no, ale dobrze tylko nie ma. W sensie, tak już na to, ile mi razy dosyłali nowe wersje, tak dobrze tylko jedna osoba się skarży, bo ja też nie byłam pewna. W sensie, jak ktoś mi wysłał na przykład 3 razy wersję, czy to jest nowa wersja, to jest nowa wersja, to ciężko upilnować mnie, a spróbowałam z czasem.
Nie ma tego. Nie ma połączenia z siecią szpitalną. Na dole nie. On na ten temat z siecią szpitalną się nie łączy. Musi być do IPAX-u połączenie do sieci szpitalnej.
No to nie czekamy. On może podglądnąć?
On tak.
Robię tu, żeby podglądnąć. On nie wiem, czy umie oglądać.
Ale wiesz, jak się, jeżeli, no też jeżeli ja na przykład dostaję w ostatniej chwili pracę zatytułowana poster 2, to też jest taka kwestia, że no to są takie błędy, które ciężko uniknąć, więc no, mogło tak być, ja nie mówię, że nie, ale chodzi o to, że no, była zatytułowana na przykład poster 2 i ja sama musiałam tytułować, no nie wiesz, o co chodzi. Więc na przykład może w tym folderze się pogrupowało i było tak samo podpisane na przykład, nie? Ale nie będzie problemu, jeżeli mam na mailu i faktycznie jest ta druga wersja, to naprawdę przepraszam Was, to teraz wyświetlimy, po prostu powiemy, że wrócimy na koniec, ok? Tylko już może po wszystkich, tak? Ok? Nie mam też problemu, bo mogło być tak, że po prostu mieszała mnie, ale to wygląda to głównie, że tytuł był... No zaraz zresztą zobaczymy. A czy coś jeszcze chciałam? Ale ogólnie z tej w sensie teraz zapomniałam tylko tej mail. Ale myślę, że tylko nie jest, może nie widać jak bardziej śmierci. No bo uważam, że dobrze poszło i dobrze dostałam, Agata. Kiedy dostałam? Jest, to ja. Dobra, pisali, jakie pytanie? Naprawdę wszyscy śmierci Siedzę w nerwach. Myślałam, że pracę zdenerwować, ale nie było się swoim domem. I wszystko idzie wyżej.
Jasne, jasne. Wszystko i tak powiedziałem.
Tak jak widziałeś,
Ale dziwne, że...
no naprawdę, także no, tylko zwróć uwagę, że...
Uznać, żeby jako estetyka po prostu.
Myślę, że tu nie ma do myślenia, bo się praca podobała i tak, więc...
Podłączam. Wow. Aha, muszę tu zaznaczyć, że włącz. OK. Jasne, OK.
Teraz gram na...
Dobra. A, no mogę, no. Teraz
Jakbyś mógł skopiować po prostu tylko na pulpit, OK?
A jeden drugi się otworzył? Czy to jest... O, to jest ten.
No dobra. Po prostu zgraj to na pulpit.
Żeby się... Dobra.
Otwórz tamtą starą. Zminimalizujesz to?
Tu było... Nie, no. Tu. Nie, to jest twój chyba.
Tutaj jest na pulpit.
Wyszli do pulpit. Zmienić nazwę? Nawet może nie trzeba. Teraz jeszcze sprawdźmy, czy działa. No, tylko że jak się otworzy skrót, to może być tak, że nie będzie się otwierało.
No, czekaj. Możemy
To telefon. Ale czekaj, może ja wyjmę swoje.
Wyjmij go i... Chyba to zamknij okno może.
Myślisz?
A nie, bo ty nie możesz wysunąć.
No, ale jeszcze raz. To jest moje chyba, tak? Czy coś twoje jest?
Jest jedno moje.
A to?
A jakbyś tak po prostu skopiował, nie wyślij tylko kopiuj, w sensie przeniósł tak na pulpit normalnie, tak wiesz, przesunął, wtedy może się jakby skopiuje i nie jest potrzebne.
Dobra, bo teraz usunąłem ten, ale zobaczymy. Wysuń. OK. I teraz możesz, no możesz sprawdzić. To jednak, to skrót racji. Dobra. Ojej. A ty jeszcze nic nie zjadłaś i ja jeszcze tobie zabieram czas.
Potrzebuję się napić za chwilkę, ale to jeszcze jest pół godziny.
Co, otwiera się?
I po prostu przeciągnij.
No, jasne. Aha, bo to już się nazywa nie poster, tylko Dawid.
A ty na tym F chyba miałeś.
To jest dzisiaj?
Nie.
Nie?
To jest w nocy, godzina. Może wpisz jednak poster, bo można
15, co dziś? Aha. Nie, przeniosę, zobaczymy.
Dobra, okej. Czyli po prostu po wszystkich jeszcze wyświetlimy tylko sam poster, ok? Powiemy, żeby zwrócić uwagę, że była nowa wersja.
No, a jeszcze możesz sprawdzić.
Otwierać. Dobra, i ja otworzę to później.
No dobrze, dobrze. Dzięki.
Proszę bardzo. Zdarza się, no.
Żeby oglądać nasze, a my mamy numer 14. Jeszcze ostatnia prezentacja od nas.
O, coś tu przyszło dalej. A dobra, nie, okej. Teraz będzie
A numery
11.
się nie zmieniają.
Zmieniają się? Bo tylko tam się nie zmieniają, wiesz, bo nie wyświetla to jedynki, ale to jest 11. Teraz będzie 11.
Tak niesamowite mają szczęście z tym przeciwnikiem ludzi na tym ludziach, jeżeli chodzi o młodych, nie? Większość z nich potrafi wyjść i całkiem często sobie rozmawiać.
Wiesz co, no, widziałem to na tej konferencji rok temu. No. Myśmy mieli dużo z naszego koła w tej chwili w tym pole, a no, oni by wychodzili, bo skończyli studia. I Kuba powiedział, że nic nie wysyłamy i w tym roku oni po prostu kompletnie nic nie wysyłali, to widzę. Natomiast tutaj bardzo fajnie są te prezentacje, na bardzo dobrym poziomie, świetnie przygotowane. A metodologicznie właściwie nie bardzo jest do czego się doczepiać w większości tych prac. Kwestia prezentacji, no to oczywiście
tutaj się uczy całe życie.
Całe życie to jest trudne do, powiedzmy, takiej jednoznacznej oceny, ale fajnie.
Na przykład nasza chirurgia piersi ruszyła od tego czasu wcześniej, że pewne znane ci osoby, jak zobaczyły z daleka żyłę pochową, to mówiły, że koniec operacji, nie? A już nie mówiąc, co dotykamy. Natomiast no, oni robią taki bardzo, no jednak trochę ograniczony zakres chirurgii onkologicznej, nie? Bo robią mało z przewodu pokarmowego, dlatego myślimy w takim naturalnym sposobem ewolucji, że też byśmy się włączyli te specjalizacje, tak samo jak daje. No bo to moglibyśmy się włączyć. No i najbardziej.
To jest kwestia po prostu uzgodnienia z dyrekcją. Zostało to uniwersyteckim.
No i zależy im na pewno na tym, żeby coś tam...
Jesteśmy szpitalem na bazie, nasze kliniką na bazie szpitala, w związku z tym są rozliczenia i inne priorytety na pewno jest zdecydowanie ciężej to pewne rzeczy.
Ciekawe jestem, jak oni podejdą do tego systemu specjalizacji, czy
będą wymagać, żeby się przenieść, w sensie specjalizantów na te całe 2 lata, czy nie wiem, ile to trwa. I będą tylko poradzić nimi, czy w systemie dochodzącym. Zobaczymy.
Wiesz co, no nie wiem.
Się w to w ogóle angażować, bo to niestety jakby moje zainteresowanie mogło się wiązać z tym, że zostanie alokowana grupa ludzi, co jak gdyby jakiś system formalny rozliczeń tego wszystkiego, co w ogóle mi nie bardzo pasowało.
No i tak, jest was ile? 4?
Już co więcej jest. Piotr Wichter, Antek Szczepanik, ja, Diana, Tomek Gach, Radek Pach, 6. Teraz chyba ma się otwierać Bober, Łukasz Bobrzyński i taka Kasia Gara. Mi się udało, że nie, więc to no, powoli robi się no, prawie tak samo duża populacja jak tancerskie.
Znaczy, wiesz co, no, problem chyba zaistniał i zaczął istnieć na pewno rekomendacji i oczywiście podpisywania dawno temu nie było mowy o tym, żeby specjalizację studiów z akredytacją, jak również rozliczanie pewnych rzeczy z NFZ-em, no to nagle to ruszyło.
Jako chirurg ogólny no, masz dosyć ograniczoną możliwość specjalizowania się, no bo jeżeli nie robisz jeszcze tam, nie będziesz robić nie urologii, jak nie robisz urologii, no to
akurat ten system uważam, że jest bardzo dobry. Poza tym
ja się dużo nauczyłem.
Patrząc z perspektywy specjalizacji, o wiele więcej niż 3 lata temu żeśmy zdawali egzamin, nie 3 lata temu. Muszę Ci powiedzieć, że z perspektywy tego jest to najbardziej produktywny dla mnie okres czasu. Uważam, że nabrałem zupełnie innego spojrzenia na wiele różnych aspektów pacjentów i ten czas był dla mnie w pełni korzystny. Ja bardzo dbałem. Bardzo. W takim nawet zakresie ograniczonym, jakbyśmy tam byli, ale nawet z tego zakresu też nauczyłem się myśleć zupełnie inaczej. Strategicznie podchodzić do tematów wielodyscyplinarnie, myśleć o tym, żeby...
Nie tylko wyrzecznięcie jest najważniejsze, tylko
sensowne myślenie i tak dalej. Tak jak teraz ostatnio przeczytałem w Ekspresie chyba, czy coś takiego, że ma być jakaś zmiana zasad tego rozliczania tętniło i wprowadzania tego pakietu onkologicznego, że ma być odejście od konsyliów wymaganych i żeby nie było to tylko, powiedzmy, rutyną, która się stała. Muszę Ci powiedzieć z własnego tylko naszego podwórka, że ja jestem zadowolony akurat z tych konsyliów. U nas spełniają swoją rolę. Ja mówię tylko o nas, bo nie mogę się odnieść do żadnych innych oddziałów. Ale mamy raz w tygodniu osób przychodzą laryngolodzy, urolodzy, onkolodzy, tylko ginekolodzy. Od nas na stałe jest 4, która musi być, nie? Czyli radiolog, radioterapeuta i onkolog, ktoś z nas jest. Muszę Ci powiedzieć, że to jest bardzo dobre. Jest to jakaś rozwój albo wstępny, albo po prostu...
Dla mnie największą korzyścią jest to, że nie ma tak kalendarnie głupich nie ma na dwa, tylko po prostu idzie i ma i nie czeka na to miesiące, bo na przykład tydzień czy prawda? Tak samo z tomografią czy rezonansem. No,
dokładnie tak. Zmieścić w jakimś określonym czasie. W jaki sposób?
A dobrze wiesz, ile tych wysiłku wymagało zorganizowania tego bez sensu. Człowiek się skupiał na rzeczach, które
proszę Cię,
albo Ty dzwoniłaś, mówiłeś na pacjenta,
proszę Cię, żebyśmy...
To jest zdecydowanie
określony czas, musi się dotrzeć.
To jest zdecydowana korzyść.
Oczywiście, ja nie wiesz, że tutaj robienie czegoś tylko dlatego, że kogoś masz znajomego, że ktoś poprosił, że bez sensu. Oczywiście poza całą sprawą papierologiczną.
U nas się jakoś tak, dzięki Bogu zdarzyło, że ktoś poszedł po rozum do głowy i nie scedował tej całej formuły jak gdyby prowadzenia pacjentów i monitorowania ich na lekarza, w końcu zatrudnili jakąś panią, która siedzi w papierach i to wszystko robi. A ten, no, a nie ty jesteś, no to u nas dzięki Bogu od tego odeszli, no bo ja sobie nie wyobrażam człowieka, który miałby pilnować lekarza, który miałby siedzieć nad kalendarzem i pilnować, że tu zadzwoń do tego, tu tam zadzwoń do tego, a wiem, że były takie zakusy u nas, jakieś to stanęło okoniem i dzięki Bogu się z tego wycofali, bo to jest horrendalna praca. Nie, ale ja widzę dużo korzyści z jego pracy, zdecydowanie. Ale to będzie niemożliwe, moim zdaniem, bo trudno inaczej określić. Słyszałeś, jaka była na przykład systemu informatycznego, którego zamówili, tak, ale wiesz, nawet, ale o ilu mówię, który działał w raportowaniu, chyba nie ZUS-u, a może ZUS to była, może nie, i działał co rok, podaje tam ileś milionów złotych, a na końcu okazało się, że nie ma co właściwie. Nigdy nie będzie życie jest nie do przeskoczenia. Tylko chodzi na rywalizację różnych stref wpływu, bo jeżeli wszystko stanie się jasne, to możliwość kombinowania spadnie do 0,1%. Beneficjentem tego wszystkiego. To są przecież olbrzymie pieniądze, środki katedralne, i tak dalej. I wiesz co, ja oczywiście nie chcę nikomu opowiadać, że nie chodzi, ale muszę mówić, żeby każdy ośrodek, każdy szpital, który funkcjonuje w ramach systemu, który się przez internet, miał do tego zadania się spotkać. Ja nie zdziwiłem się, jestem na tworzeniu międzynarodowym, ale wiele stanów jest w systemie Stanów Zjednoczonych, rejestrowania wszystkich aspektów. Ale zdziwiło mnie to, że goście z Chin czy z Rosji opublikowali pracę na podstawie danych, do których uzyskali sobie dostęp. Uprawnione. Coś, co na punkcie naszego zupełnie niemożliwe do zrealizowania w jakikolwiek sposób. Gdzie jest kancler, co oczywiście to jest jakaś strona. Kolejne są wiadomości do kwartału. Ja pamiętam, że jak ja z czegoś szukałem, to tutaj były dane, na przykład w ogóle zapisu, dane do wyznaczenia. I to tak było. Więc to wiesz, to tam funkcjonuje to musi. U nas dane są sprzedawane. Po prostu jest to jest nowy zapis. Ja skąd mam to sobie? Ja zrobię szerokie pojęcie. Bardziej ważne. Niezależnie od tego, że są pieniądze. Nie ma jakiejś kontynualnej śniadania, godziny, idziecie do roboty. To jest rząd. Wypuszczam. Dobra, i wielki parę złamały stąd. Życie było tak proste. Władze.
Albo się ma, albo się jej nie ma. Słyszę moich rodziców, gdzie nie to nie sztuka być więcej niż prezydent Rzeczypospolitej. To jest wytłuszczone. I to oczywiście w artykule jest podkreślone. Dlaczego rektor Uniwersytetu Jagiellońskiego ile on się lat musiał? Tam, gdzie to było? W Polsce. Wiesz, ja teraz wyglądam na blok, czy wiązka zawodowa.
Przynajmniej się całym szpitalem.
Piątek na super. To znaczy, że rektor Nowak ma ale akurat wiesz, jak się przypie, wiesz, tak to 2 razy więcej niż prezydent. No to takich rodziców jak prezydent jest dziesiątki, którzy więcej zrobią. Tendencyjnie pojęcie tematu akurat.
Ale w jakimś aspekcie prezydent jest pozbawiony pana rektora.
Nie, poczekaj, no bo w Stanach Zjednoczonych prezydent też nie ma. Ale to dobrze płacą Narutowiczu, jeżeli on prezydent ma 16, a on ma 3. Dowiem się o czymś, o czym w ogóle nie wiem. Jeżeli prezydent mogę powiedzieć, prezydent ma 16, a Wojtek ma 2 razy, to ma 32. Ale to jest na zasadzie tego, że jest pracownikiem szpitala Narutowicza, tylko że nie, podobno ten dokrynolog zarabia to w ciągu. Natomiast jeżeli chodzi o zarobki nas, to wydaje mi się, że są zbliżone do naszego szpitala uniwersyteckiego. Nie. Tam jest różnica, że rzeczywiście czy
Wtedy ten podchodzi go, to że on jest systemem.
Na pewno. A czy to prawda, że tam to znaczy, nic mi o tym nie wiadomo i nie uczestniczyłem w nim. Może ona była gdzieś na jakichś spotkaniach.
To była czarna msza, żeby wrócić.
Może to dlatego jest jeszcze 8. Myślę, że wiesz co, ja mam tam trochę rzeczy, które są podobne w tych prezentacjach. To zaprosimy.
Oczywiście. Nie zapraszam do dyskusji, a chciałbym podkreślić, że ponieważ ten podział nie jest zupełnie specjalny, tak jak pokazałem, a powyżej 0,80 tak jest dowolenie, to prawda, ale faktycznie naczynia w większości pacjentów wysokiego ryzyka nie życzę do końca, muszę operacji.
Chyba tak, to Monika Ruska.
technicznej. Jeśli nie mamy tych to nie dowiemy, że... Dziękuję bardzo.
Te nasze punkty liczycie średnie?
Welcome back. Now I would like to ask the next presenter, Monika Orłowska.
Good morning, ladies and gentlemen. I represent students' scientific group of the second department of surgery at the Jagiellonian University Medical College. My subject presentation is the influence of ratio PLT to WBC on the complications and recurrence rate in bleeding from upper and lower gastric. We should know that bleeding from disease in the surgical wards. Did we choose choir hospitalization? Their mortality ranges research 6 to 14%. Rapid clinical assessment. What should we do if we weren't sure the source of bleeding? Upper or track? Try them. We enrolled 223 patients, mean age 67 years, from the second department of general surgery in Krakow. 131 men and 82 women. 137 show bleeding from upper GI tract and 86 show bleeding from lower GI tract. We analyzed the results of complete blood count before and during hospitalization among patients. We took into consideration the ratio PLT to WBC between complications and recurrence and mortality. 16 complication, that means 70%, 16 recurrence and 1 death occurred. The ratio of PLT to WBC is not correlated with relapses and complications. However, we found this ratio in bleeding from upper to lower GI tract. The ratio PLT to WBC in patient who's bleeding from patient who in patient who's bleeding from lower GI tract. Our results has shown that patients who's bleeding from I'm sorry. Our results has shown that generally ratio PLT to WBC in patient who's bleeding from upper and lower GI tract is above 20, and with when the this ratio increased to 15, that means we have bleeding from upper GI tract, and when this ratio decreased and increased to 25, we have bleeding from lower GI tract. The ratio PLT to WBC seems to be a good aim of our research, and we are convinced that it could be a good method to diagnose and help our patients in a different way.
Thank you. Would you say that, I guess that for presentation of this result, you should do a little bit different analysis, more showing a specificity, sensitivity, positive and negative value of your ratio. And one remark. And second, what would be, according to your opinion, your explanation for this observation? Why this parameter differs between upper and lower GI tract bleeding?
Because bleeding from upper GI tract is more intensive, and we lose most of blood, and this is the answer, I think.
It's rather showing us the intensity of bleeding, or bleeding versus chronic bleeding, rather than localization. So it's very indirect. So by showing us that the bleeding is acute, you're assuming that it's from upper GI tract, So this shows us very indirectly through the mid-step of intensity of bleeding that it's rather upper or lower.
I have two questions. First, why did you choose this PLT to WBC? Most research in the area that is number one, and number kind of acute conditions. Some of them is with either various blood components probably, or with saline and other things that could markedly affect those measurements. So timing of measurements and interventions before this kind of measurement could markedly influence your results. Do you have any information for this?
For first question, lymphocytes are the most, at the last time, is the most they don't have these results, and we try to find something more associable. And this way, we choose PLT to WBC because every morphology have got this. But for the second question, I don't have information.
Did you check for other parameters of blood count? Why exactly this ratio? Maybe hemoglobin level will be better, or I don't know. Any comparisons like this?
No, I don't have.
Okay. Thank you.
And we'd like to invite the next person.
Ladies and gentlemen, my name is Artur Kacprzyk, and I represent Student Scientific Group at Second Department of Surgery of Jagiellonian University Medical College in Krakow. The scientific paper I would like to present is called Analysis of Readmissions of Patients Treated in the Hospital Emergency Department because of abdominal pain. Abdominal pain is a common cause of complaint in the emergency department. And despite the continuous development of diagnostic methods, there are first abdominal pain with a particular is patients who were readmitted. From November to October 2015, 8,500 patients were treated in emergency department of the Unicra himself, complained about abdominal pain, and we needed to continue the treatment hospital. And the most often, in 48% of cases, they were admitted to the surgical ward. After that, 50 of them were qualified for the surgery, which was the most often caused by appendicitis. There were 20 appendectomies performed on patients who were admitted from emergency department. In patients, doctor decided to continue the treatment in non. But now the group which is in the center of our attention, 523 patients home after their first visit in emergency. 15% of them decided to come back to the emergency department of improvement or worsening the symptoms. After that, 17 of them were qualified for the surgical procedure. And again, appendectomy was the most surgery on patients who were readmitted to emergency department. In 5 of cases, patients who had appendectomy were initially discharged from the department. Furthermore, among 95 after ED admission, 17 were initially discharged home and came back to emergency department because of lack of improvement. In the conclusions, abdominal pain is a common problem in emergency department. In cases with surgical approach, appendectomy was the most commonly performed surgery. Due to the fact that the most commonly performed surgical procedure on patients who were readmitted was appendectomy, symphysis should attract particular attention in the hospital emergency department. Thank you for your attention.
Thank you very much. It's a very important message that when we have to base our decisions about sending patient home or admitting and operating him, if this decision is based on very subjective data, like our clinical experience, our physical examination, we make a lot of mistakes, and you proved it. I guess, however, I don't know, this is my question, because I guess that this number here is much lower than the truth number, because out of 3 patients, at least some of them may have gone to some different places. Or
No,
did not
we haven't database for
you don't have
checking it.
data about that. So we may assume that if those 79 returned, probably similar number went to other needs, and that will be studied, but we may assume so. That's striking how many mistakes we do if well, of course, there are many factors that influence that. If it's 1 o'clock in the morning, if it's too many annoying patients, too many patients waiting for surgery and you're in the hurry, perhaps those are some psychological aspects that make this decision difficult. Many clinical presentations at the beginning may be so unspecific that even experienced surgeon who pays enough attention, who pays enough time for the mistake. It's important message.
I do agree with Professor about this clinical importance of your observation, and I'm curious about the population of patients who underwent appendectomy. Do you have any data to show us that all of them actually had appendicitis, or just appendix were removed?
Yes. We have this information because we analyzed the database of the surgical ward, and we have information about the operations which were performed on these patients.
So
it was appendicitis.
So there was no even a single patient who underwent, for example, I don't know, diagnostic laparoscopy or laparotomy, and you found
in this group.
Okay, thank
wasn't
you.
such a patient.
Which is another important. Thank you very much.
Thank you.
And we would like to invite another person.
Good morning, ladies and gentlemen. My name is Wojciech Stojak. I am the member of a scientific group at the Department and Clinic of University Medical College. And as we know, the treatment for surgery or kids best depends on the stage of the disease, the PSA level, the Gleason score, the man's age and his general health. And the treatment discussions often focus on both of the therapy with the of the surgical therapy may be done when the cancer is still in organ with G1 and laparoscopy. The incidence of incontinence after this procedure ranges from 8 up to 56%. And in some patients, even the transient lack of control in urine, social isolation, the sense of disability, and etc. And if we tried to check if pelvic floor muscle therapy in men suffering from transient stress urinary incontinence after laparoscopic radical prostatectomy was effective. 14 and April the 15th, April the 30th, 2015, we excluded the candidates to implant an artificial therapy, which consisted on strengthening, relaxating, controlling, and stimulating muscles of the pelvic floor. And in order to achieve results, we used incontinence quality of life questionnaire completed before and 3 months after the onset. Some of the questions I chose, and for example, those were: I worry about sneezing, ending up from sitting. I don't feel free to leave home for long periods because of my incontinence. My incontinence, I get less enjoyment out of life because of my incontinence. In those answers, it changed from before the treatment at all, after it, and there are practically no extremely answers after the 3 months of this. And so this positive influence, more questions. From controlling, we showed that more than 50% of patients had control of incontinence and quality of life. And pelvic floor muscle therapy in properly selected patients is an effective, safe, and improving quality of life method, especially when the external sphincter muscle of urine. Thank you.
Those are excellent and very good presentation of those results. And they stress quite obvious information that there is a lot to do on the patient side. So not only we are those who are to provide the patient with a good result, the patient has to work on it by himself. It reminds me of a joke. Probably it's not a place to tell jokes, but why not? There was a patient who had incontinence, and he was going to every doctor, every urologist in town complaining, and nobody could help him. Finally, he found someone who sent him to a psychiatrist, and then the patient has this time ever. And then the doctor who sent him to psychiatrist met him on the street and asked him, "Oh, how is your psychiatric therapy doing?" And he said, "Excellent, excellent. So did it help? don't you have incontinence? No, no, doctor, I have incontinence, but now I'm proud of it. Okay, no, very nice study.
I would like to ask another person.
Ladies and gentlemen, my name is Monika Okante and I represent Student Scientific Group at Second Department of Surgery in Jagiellonian University Medical College in Krakow. And I am going to present the study entitled Incidence of Early Symptom in Pancreatic and Ampullary Tumor, Single Center Retrospective Study. As we all know, there are no characteristic signs that could indicate the development of pancreatic and ampullary cancer, and this is why we wanted to analyze early symptoms occurring in patients hospitalized at Second Department of General Surgery in Krakow in years from 2012 to 15 to find there are some signs that show alertness. Of early symptoms were collected using symptoms as well as prior to final diagnosis were taken into account, and we excluded patients with neuroendocrine tumors. Our study included 83 patients, 75 of which had adenocarcinoma, 5 had intraductal papillary mucinous neoplasm, 2 had mucinous cystic neoplasm, and 1 had pancreatic intraepithelial neoplasia. We divided our patients into 2 groups according to the localization of tumor. Group A included of head of pancreas and ampulla of Vater, and Group B included of both within 2 years prior to final diagnosis, and in 2 patients there was not. Common symptoms in Group A: abdominal pain, weight loss, back pain, constipation, and fatigue. Common symptoms in Group B that included 12 patients were abdominal pain, weight loss, discomfort in abdomen, and bloating. As we can see, statistically significant differences between both groups were incidence of jaundice, bloating, and discomfort in abdomen. To solve the tumor, symptoms occurred in 2 years diagnosis. And that alarming symptoms, most patients complain of abdomen, fatigue, bloating, back pain should raise oncological alertness. Thank you very much for your attention.
I must say that I didn't know that this study is done. So it was interesting to hear the results. And it's a very important message, actually. There are 2 for me from this study. It was very clearly presented and very nice. One is that there are early symptoms of cancer and that clinical evaluation is a very important thing. Second, that even if the patient will come with bloating, discomfort, pain, slight weight loss, we will not probably think about pancreatic cancer. And even if we will think, then our trouble will begin. There are patients in whom we know just from clinical experience that this is typical, absolutely typical clinical picture of the cancer of head of pancreas. Painless jaundice, weight loss, MRI, and there is no tumor, and how to make the decision about everything, about surgery, etc., etc. So probably even though we learned from this paper that there are some symptoms, that there are some more or less alerting situations for us, we will not be able to draw very practical conclusions for the future. But it's a very nice study, I must say.
Congratulations for your great effort. You recapitulated the information that about 70% of patients with pancreatic cancer, especially in the head of the pancreas, had those 3 cardinal symptoms. And it is quite commonly known since many years. But did you do any kind of analysis that how those presentations affected the ability to resect? Did those patients with jaundice were more likely to receive radical resections? I mean, was jaundice is only one of the very, very few clinical factors that may force us for surgery. And normally, the therapeutic delay time between the onset of symptoms and proper surgical treatment is shortest for jaundice, while those for pain and all the wait up to 6 months from the onset of their symptoms. Do you have any data to show us that, for example, jaundice more commonly forced patients for surgery, and those operated due to jaundice were more likely to receive resectional surgery?
So thank you for this question, and we try to find some correlation between resectability and appearance of jaundice, but we didn't find anything statistically significant in this.
Another question would be very interesting. If most of those patients had symptoms for 2 years, did they do any evaluation? Where they evaluated? Did they go to a doctor? You know what I mean? So they had some problem, and what the doctors did about it? Did the patient go to a doctor? Did you try to find this out? What was the diagnostic workout of this patient? So the fact you documented that most of those patients had symptoms, some symptoms for at least 2 years. But what was the fate of the patient? Evaluate to which doctors they went, what tests, what studies did they have? Do you know this, or?
No, we tried to talk with this patient, but we only talk with about 20%, so we don't have such all our patients.
Okay.
So.
Yeah, thank you.
Okay, so you're.
Dear professors, colleagues, ladies, to a group of malignant neoplasms located most commonly in stomach. Epidemiologic data shows that morbidity of GIST tumors is around 15 new cases per million per year, which give us 600 new cases per year in Poland. The best long-term clinical results are after surgical excision. As opposite to adenocarcinoma tumors, they don't require lymphadenectomy, what makes them perfect for minimal invasive surgery. In response to significant growth of interest in this way of surgery, I would like to present an alternative of stomach GIST tumors with peroral material extraction. I hope you will become interested in this procedure after my presentation. We carried out retrospective analysis, a group of 6 patients who underwent laparoscopic GIST resection in 2nd Department of General Surgery in Jagiellonian University. Time of procedure, number of complications, total blood loss, number of incision site hernias, and time of hospitalization. All patients underwent the same procedure, which can be divided in several steps. First step is trocar insertion, 1 10mm story and right subcostal area. In the same step, gastroscope is being inserted. Gastroscope is being used to demonstrate specific tumor localization by area, what we can see at picture 2. which shows us view from abdominal cavity after tumor cut out. And then by using, after that step, tumor is being placed in special pack, and then by using the gastroscope, is being removed per oral cavity. Gastroscope gives us plenty of advantages: precise tumor localization, checking of anastomosis leak, and per oral material extraction with necessary. The results of our study shows that average time of procedure along with material extraction lasted a little bit. Average amount of blood loss was around 8 millimeters. There were no deaths, and incision site hernia was not present in any of treated patients. Important issue is tumor's diameter, which allows us to use this procedure. In our center, it was 4 centimeters. Analyzing these results, it can be stated that advantages of this procedure are small number of complications, small amount of blood loss, small time of surgery, and furthermore, this per oral material extraction limits the size of postoperative scar. I hope we'll share the opinion that this is the conventional way of treatment in such neoplasm. Thank you.
Thank you. Some methodological remarks. We learned that those were 6 patients from you. It's not set here. You present quite a lot of data. Perhaps I didn't find it, but I'm nearly sure that this is not presented. And second thing, that's a very interesting, used in relatively small tumors. The interesting thing will be if you will present it in the bit broader context. For instance, patients in whom we tried and we failed. Because I remember at least 2 patients in whom we tried, but the tumor was too big, so we had to do mini laparotomy. And this will show you how frequently this method is effective, how frequently it could be used. And you just said it, but if you will present data that the use of gastroscopy in during local resection of GIST tumor, one thing, it's very good for POS, for per oral specimen extraction. But you just mentioned it, but it should be presented differently here, that it's very, very helpful in localizing small tumors because there are different patterns of growth of GIST. Some are growing only inside and they are not visible from the outside. And then gastroscopy is extremely helpful. And I don't remember how many cases like that we had, but in our database you could find it. And the last thing is that the only method to evaluate for airtightness of the anastomosis, because in more narrow spaces, like in sleeve gastrectomy, in rectum, in after total gastrectomy, you can use blue dye under pressure for a leak test. In case of large volume, like stomach, you would need to fill it with 2 liters of blue dye to check for so gastroscopy here for this use. So in your paper you should strike some other positive aspects of use of endoscopy during laparoscopic resections of GIST. That's my remark.
Except from those advantages of this hybrid approach with endoscopy and laparoscopy, I'm not much convinced that if you a priori centimeter as a maximum tumor that can be extracted orally. Will you require a real mini laparotomy to extract such a tumor via trocar hole? In most cases, the tumor is much smaller than 4 centimeters for those small GISTs, and putting it in a bag will not necessarily require a huge laparotomy.
Yes,
Are you convinced that if you limit a priori this population to only those with 4 centimeters size, you'll get a lot of benefits with removing the specimen with endoscope?
Yes,
Except those benefits of checking wall integrity, etc., etc. if you focus only on the benefits of extracting the tumor with this oral way, I'm not very much convinced that it's very, very profitable for the small size.
Yeah, but especially in, for example, in very obese patients, making a little bit more large laparotomy and then suture it, it could take much more longer than per oral extraction. I guess. Thank you.
And the next person.
Good afternoon, honorable members of jury at the audience. And I represent a scientific group at the second department of surgery at the Jagiellonian University Medical College. Our study, which title is, Does the preoperative platelet count determine the outcome of laparoscopic splenectomy in patients with cytopenia? Elective laparoscopic splenectomy is a routine method for treating cases of refractory ITP in patients not responding to the first-line therapy, like glucocorticosteroids or immunoglobulins. And the aim of our study was to assess a correlation between the preoperative platelet count and an outcome of laparoscopic splenectomy, intra- and post-operative complication rate. Now I would like to tell about materials and methods. An operation on the spleen at the second department of general surgery, Jagiellonian University Medical College, over a 17-year period. We selected 197 patients with ITP at the average age of 40. 74 were men and 123 were women. The mean spleen size was 12 centimeters. And then we divided patients into two groups. First group include patients with the preoperative platelet count lower or equal 50,000 platelets per, and the second group includes patients with the preoperative platelet count higher than 50,000. Results are following. Intraoperative complications occurred in 5 patients. 60% of them were in the group 2, whereas 40% in the group 2. Higher in the group 1. Differently, only 21% of post-operative complications occurred in the group 1, whereas 79% in the group 2. However, all those parameters did not reach statistical significance. We also compared the presence of accessory spleen, mean operating time, and operating technique. None of them were statistically significant. And comparison between the group 1 and the group 2 revealed that the strongest predictor for the post-operative blood transfusion was the preoperative platelet count, and this parameter is statistically significant. After analyzing this data, our conclusions are that the preoperative platelet count does not significantly influence the difference in intra- and postoperative complication rate and the mean blood loss between these groups. And the second is preoperative platelet count higher than 50,000 platelets per microliter decreases the risk of postoperative blood transfusion. Thank you very much for your attention.
Once again, that's another presentation with too much text, difficult to read in this form of presentation, so remark for future presentations. You touched the subject that is very important in spleen surgery, but you did not address it, in my opinion, profoundly enough. 50 is a standard for safety of operation. We have it in the standard, especially anesthesiologists. They will tell you no to any surgery in patients with platelet. This group of patients in whom primary goal of surgery is to increase platelet count, you can do safely laparoscopic splenectomy. The only thing that you are risking is that you have higher risk of blood transfusion. And that's the main point of the study, which should be here stressed. So what you have proven here in your study is that this patients with, and probably you should address here the subject, how you could do it, what you should do to do it safely, that it should be with perioperative platelet transfusions just before splenectomy, just after clipping the splenic artery. And that's one thing, that there are some surgery to be safe. And then if you fulfill this, you can do it safe. Groups, how they are prepared prior to surgery, there will be striking differences. They will get so there might be some immunosuppressants, perhaps some platelet stimulating factors, although those are very expensive, so they are rarely used. But platelet transfusions, which in other group are not used. And this is very important, especially those platelet transfusions, because if you want to show in your only results and safety, but the truth outcome, the reason for surgery is thrombocytopenia. To increase the platelets, that's your aim, that's your goal. This is why you operate. So you should evaluate how successful you were. And this might, so not only early outcomes, but later outcomes. How many of the people responded to splenectomy? How many of them have higher platelets? In which range? How many of them can quit steroids? And is it influenced because patients in extreme low platelets? I remember a patient operated with a platelet 0 with continuous platelet transfusions, that by transfusing them platelets from donor, increasing the chance that they will not respond, because the background is autoimmune and you're transfusing them with platelets that carry different, and this is, I would say, it's a very good paper, methodologically very nicely presented. You said what was the truth result of this study, but you should treat it as the beginning for further study. There is much more to be done in this subject, and I guess that then it will be a very nice paper.
Can I comment shortly? Because from what I remember, in our database, we didn't have precise information about the reaction for the splenectomy, like in the follow-up of, for example, a few months after the operation, and about this platelet group. Generally, in all our patients, there were 16 platelet transfusion, and 13 occurred in the first. Thank you.
That's good that you know that.
Do you have any information about timing of measurements? Because considering all the factors that were already mentioned, there could be surgery. Were those measurements done, I don't know, immediately before surgery, a day before surgery, or something happened in between measurement and surgery?
Do you mean the measurement of the count? Right? We choose
Prior to surgery, we go with less than 10,000. So the morning before surgery, and for the remaining, it's the day before surgery.
Thank you very much.
And the next presenter, and last.
Good afternoon. My name is Alexandra Gauden, and I am a representative of student scientific group at the Department of Thoracic Surgery in John Paul II Hospital.
Because you had changed the right and right,
It was last minute, so. I'm really sorry.
I wish that during adult sessions or adult congresses, we will have so few mistakes. Don't feel bad about it.
Okay, so and I am glad to present you a study concerning EBUS so EBUS transbronchial needle aspiration, EUS fine needle aspiration, and combined ultrasound guided needle aspiration, which is CUS, are mainly used to evaluate mediastinal changes such as lymph nodes enlargement and cancer infiltration. The CUS is mainly implemented for non-small cell lung, and the variety of advantages of those methods should be confronted with the complications, and that was the aim of our study. We was to identify the complication rate of EBUS, EUS, and CUS, and that's why we designed a retrospective study. We browsed over 6,555 patient charts, and we looked mainly for pneumonia, hemoptysis, and fever. In patients who underwent those techniques in our clinic in last 6 years, and 1,000 lung carcinoma, and about 5,000 had other diagnoses such as sarcoidosis, pneumoconiosis, or adenopathy. And let's move to the results. So no mortality was observed. However, the complication rate reached 4%. A table picture a specific amount of our complications. You can see from the first graph, this is more likely to occur in cancer group in comparison to other diagnoses. And we also compare specific types of CUS to EBUS, which is a reference method. And we detected that fever is more likely to be provoked by a CUS method. And the last graph shows that puncture through esophagus is more likely to cause fever than transbronchial puncture. Okay, so I want to emphasize that our study is the biggest study as far as the amount of patient is concerned that detects complication rate after those techniques. And to summarize, I want to say that endosonography is becoming a gold standard in diagnosis of pulmonary and mediastinal changes. And EBUS, CUS, and EUS should be as but invasive methods with significant complication rate. And considering the development of new endosonography techniques, further monitoring for adverse events occurrence is essential. And thank you for attention.
That's a very impressive material collected over many years. The typical remark for the it should be a little bit less text, but clearly presented results very nicely, and those are very reliable data, I guess. Thank you very much.
Thank you for all the presentations. And now I would like to ask all participants. Okay.
We had one more request
yes,
from the authors of the work about the examination of urogenital area. Because there was some mistake with attaching the file, the proper file, they had a new poster and they would just want to show it that they improved their work, okay? So that would be their new work. Yeah.
That's much
They really wanted to show that, so thank you for your attention, and now the jury will decide on the prizes. So please leave the auditorium and come back in 10-15 minutes. We will tell you, okay?
Tak, jakbyśmy mogli, to by było dobrze.